This is Kate with Collective Medical. Can you hear me okay?
Yep.
Great, thank you.
I texted Diane, but I haven't heard anything back yet. Welcome everyone to the Learning Collaborative on Collective Medical. We're going to wait just a few more minutes to just let everyone else log in. If you will be patient just for about 2 to 3 more minutes. Thank you. Welcome to Greater Columbia's ACH October Learning Collaborative on Collective Medical. I am Sam Wardell. Be sure to log your name and organization into the chat box for those that are just joining. Presentations, minutes, and meetings will always be recorded and posted on the GCACH website, as well as our CSI portal. And this is just a reminder, it is reporting time, so be sure to go to the new login for the healthcarecommunities.org. Again, it's www.gcach.healthcarecommunities.org. Okay, Stacy. Stacy, we can go ahead and go to the next slide, please. And I am Sam Wardell. I'm Director of Practice Transformation.
Martin Sanchez, Senior Practice Transformation Navigator. Laurel.
Laurel, you're on mute. Sorry.
Thanks, you guys. Good morning. And this is Laurel Avila, Practice Transformation Navigator.
Good morning. This is Brittany. I'm a Practice Transformation Navigator.
Diana Halo, she is absent today. She is the program director. Welcome and happy Friday. Go ahead, Martine, with your sites.
Yep, as always, for those of you that have joined us in past learning collaboratives, this is a list of the sites that I am the Practice Transformation Navigator for. And in here, we have a couple of my sites. I see Merritt, Pedro Lopez is from there, Katie Goodell, Ken from Farm Workers, Jolene Harper from Tri-City Memorial, Alicia Egan, Sandanem Ranch, as well as Michelle Sullivan from Yakima Neighborhood Health Services. I saw Demita Morin as well from Blue Mountain Counseling. So any of others that I haven't seen and you guys are present, welcome, and thank you guys for being here.
As Martine said, so this is a list of the sites I have the pleasure of working with. Welcome, everybody. And I noticed out there, I saw Ed Marash from Kittitas Healthcare Prestige in Kittitas. Hannah Tower, who will be one of our speakers later from Comprehensive Healthcare in Ellensburg. I saw Patrick and Juan from Serenity Point in Walla Walla. Welcome, you guys. Sarah Clark, good to see you from First Step. Kendra, I saw your name in there. Glad to see you this morning. Welcome. Matthew from Lutheran Community Services. It's great to have you with us. And all the other people that I might have missed. I'm really pleased that you're here and we're looking forward to our presentation with you today.
All right, good morning again. And this is a list of my sites that I am the primary Practice Transformation Navigator for. I've seen Mike Burney from Police River Counseling, Victoria and Penny from Ideal Option, Ideal Balance, Ed from Prestige, Stacy, Melissa, and Alexis from CHCW. Mandy and Tony, thank you for joining from CVH, that's Kittitas Valley Health. Rhonda and Cheryl from Astria, and Sonia from Triumph. Thank you guys all for joining us and taking time out of your busy day to join this wonderful learning collaborative.
Today's agenda, we'll have introductions that we just completed. And again, good morning and welcome everyone. Collective medical presentation will be from 1 hour, and welcome Kate Dowd. 20 minutes for questions and answers, and I will be facilitating that. And then we'll have partner provider presentations from Comprehensive Healthcare as well as Lord's Health. That'll be 30 minutes at the remainder of the session. So welcome everyone, and let's get started. I would like to really align our partnerships with the MCOs. They have been so valuable in sponsoring our organizations, especially around for collective medical and our transitional care projects. So again, thank you for being such great partners with us and for sponsoring all of our sites. Every single cohort has been sponsored by an MCO. So thank you and welcome.
All right, so I would like to take this opportunity to introduce our speaker, Kate Dowd. She is with Collective Medical. Kate Dowd holds a bachelor's degree of social work from Northern Arizona University with an emphasis on indigenous cultures of the Southwest, and a master's degree from Noropo University in gerontology and long-term care administration. I have had the pleasure of working with Kate on this learning collaborative, but also in the past, and she brings a lot of great knowledge that I'm hoping that you guys will find very valuable. And she has shared with us that she loves questions. So as she's presenting, if you have anything that you have a question about, please feel free to put those in the chat. We will have a Q&A after her presentation. Kate Dowd, take it away.
Thank you so much, and I am so grateful to be here. As I see folks putting their names in the chat, you might recognize me or my name, as I have been with Collective Medical since 2017 as an employee, and I've had the privilege to travel throughout the Greater Columbia ACH region, as well as onboard some of your practices. So thank you all so much for joining today's call. And if I could have, thank you, I'm going to grab the screen now. And I'm going to start with a slideshow presentation to discuss both the learning objectives and cover the background of Collective Medical before I do a portal demonstration. I completely do love questions, comments. We welcome you to interrupt me at any point in time by either coming off of mute or leveraging the chat functionality so we can be mindful that we're meeting the learning objectives as we're moving forward. So the objectives for my section is going to be covering how the data flows across the Collective network to activate the care teams in real time across the full care continuum of Washington. To understand the basic functionality that the Collective platform provides for you for risk stratification, as well as collaboration on meaningful insights for vulnerable populations. And then finally, we're going to make sure that everybody here understands the basics of how do you get help and support from Collective Medical for your programs and services. So with that, I decided to start with who are my colleagues within your region available for your support. So depending on who you are in the care continuum within the Greater Columbia region, these are the representatives. For the health plan, we have Erica Anderson, and she supports all the health plans, MCOs. And then for the technical side, our support team has expanded exponentially, and we have specialized support individuals to be able to help with the health plan portals and customer requests. For health systems and hospitals, we have Katie Hill as the customer success manager for the entire state. And again, we have grown our support that Katie is here to help you as an organization in meeting objectives, goals, and milestones, while the support team is here to be able to help you with the technical aspects associated to either your integrations to Trackboard or the actual portal design. And then finally, skilled nursing facilities, FQHCs, behavioral health providers, all requests come into our support queue, and they can both help with the technical as well as if you have a more complex need, or perhaps you would like to do some clinical discovery around an initiative that you're working on, the support team will connect the correct subject matter expert at Collective Medical for your organization's needs to help you in the similar fashion that a customer success manager helps the health plans and hospitals. So I share this on the front end. So then that way, as we move forward, if you have questions or you're like, oh, yep, we definitely want to do that, you know whom you would be reaching out to be able to take the next steps for your organization. At the highest level, I also wanted to surface who broadly at Collective Medical is supporting Washington State as a whole. So the names that you see here are to show you who is at the Collective Medical leadership table and working on the strategic partnerships and relationships throughout the state. Many of you may know, but to be extra sure, we wanted to share with extreme pride that Collective Medical was purchased by Point Click Care at the beginning of this year. So what that means for you of customers of the Collective network is that now that we are owned by the North America's largest post-acute care EHR and network, we can now get deeper data from post-acute providers to share on our network to really surface meaningful information that you need for the transitions of care. As an overview, because we are specifically talking about Collective Medical and the Collective platform, I'm going to use this slide to talk about how Collective Medical has been able to use the data provided throughout Providers of Washington to create a single platform for your care collaboration needs. It is no secret that Collective Medical got our start in Spokane, Washington. So Washington hospitals were the first hospitals to connect to our network. And being your state was the first, we've had the privilege to learn with the health plans, MCOs, and down to the FQHCs as well as the ACHs together about how we can help move the data on our network in a meaningful way to support patient-centered care and ensure that the clinicians who are patient-facing have the details they need for excellent care collaboration. We do have all points of the care continuum, including new and enhanced relationships with HIEs across 43 states. So as we talk about your clients and members in your region, please know that because our network now spans 43 states, as well as the information from point-click care, we can actually surface details for you about your members out of state should they be traveling elsewhere for care. What that means is it allows you the opportunity to know in real time when folks are accessing care out of your region and still have the opportunity to do meaningful follow-ups, especially if their experience was crisis or trauma related. The Collective platform shares the information about your patient population back to you in two different ways. We push real-time notifications to providers and case managers, and many of you in the hospital, that is your primary way of leveraging the data from the Collective network. We push the notification into the track board in the emergency department, but for clinicians that might not be in an emergency department, perhaps you're a care coordinator in the community or you're a health resilience specialist, we can send notifications to you via email or text. Every customer on the Collective Medical network also gets a web-based portal. So whether you are a consumer of the one-page notification in the emergency department, you still also have your own unique instance of our web-based portal to get a deeper dive into the patient information. And that is something that I will demo and go over today, as well as define each data element and feature and function that is available to you to leverage for your case management and care coordination. So now I'd like to talk about how Collective moves the patient data in a HIPAA compliant way across the care continuum by using a patient example. I'm going to start by, again, using Washington as the example, because what we have done is that, again, starting in Spokane, Collective Medical has stood up what we call HL7s, or special connections between the hospital's EHR and our high trust certified database. These connections are in place, so then that way when patients present for care, that information moves to the Collective cloud. At the same time, FQHCs, MCOs share eligibility files, which is basically an Excel spreadsheet to identify who their active patient population is, and those files go into the exact same database as the hospital feeds. Home health, skilled nursing facilities, they send us feeds just like hospitals do, again, for that information to sit at rest within our high trust database. So as the network has spread throughout the Greater Columbia ACH region, we have the eligibility files from your organizations. And again, that information sitting at rest until or unless your patient has an acute encounter. So when your patient goes to an emergency room and they mark yes on their HIPAA paperwork that they can have their care team information shared, that immediately releases the admission, discharge, and transfer feed to our database. We then cross-check every single eligibility file and patient feed that we receive from the 43 states to verify who has an active HIPAA relationship with this individual at this point in time. We then query each of the web-based portals that we built for your organization to find out what criteria is important to your organization to know about. We additionally query all of the portals to find out what of our customers have requested a real-time notification, and then in under 2 minutes, we push the notification to those who have requested it, and we populate the web-based portals for all the customers with the HIPAA relationship with that encounter data. This way, it allows for those who have the resources to deploy in real time to have visibility that they have a mutual active HIPAA relationship, as well as the opportunity to collaborate while the patient is at the emergency department to offer either follow-up or additional services to meet that patient's need, again, in real time. For those of you who are in clinics or basically outside of a hospital, it's helpful for you to see that the hospitals receive their notifications through a track board. We have some hospitals that receive a fax. If generally our rural access are on fax, but otherwise there is an integration directly into their track board. So when the patient is in triage and says yes on their HIPAA paperwork, the one-page notification presents to those providers and case managers, and they can consume the content and any recommendations from downstream providers before they even get to see the patient at their bedside, because this notification arrives before they see your patient. For clinics, behavioral health, skilled nursing facility, we offer text notifications. So we're thinking about skilled nursing facility hospital liaisons. This is a very valuable opportunity for them to be able to support potential individuals who have returned to ED after a discharge. Email notification is an opportunity that's often quite common for care coordinators, case managers. And then finally, you also have the opportunity for our notification to come via secure fax. So some organizations feel value in receiving the consolidated one-page notification into their medical records to be able to scan into their EHR. These are all opportunities available in addition to the web-based portal. So as I had said, we push the notifications about your patients, but we also build a web-based portal that looks just like this, regardless of what part of the care continuum that you are in. So this web-based portal has been made specifically for each facility on our network. And then we worked with you and your organization to add and assign users. Total transparency, we know that hospitals are not the primary web-based portal users. It is often those of us in the downstream or ambulatory environment that use the web-based portal on the most consistent basis. And the reason being is that integration is to push the content for the emergency room providers, again, to see the recommendations and guidance from those who have the longitudinal relationships with patients. So I'm going to pause here because I'm going to now move into a little deeper dive onto the eligibility files and how it is, again, that collective medical knows who your patients are and how that information is leveraged once it comes to collective. So I'm just going to pause for questions, comments, anything in the chat I might not have known of. Okay. So as I had indicated earlier, the customers outside of hospitals, skilled nursing facilities, and home health make an eligibility file. I completely agree and have endless gratitude to the MCOs of Washington for their sponsorship model and the sponsorship offering that they provide to all the downstream providers in Washington. And it is important to know that their sponsorship is intended to help you surface your entire patient population so you can have meaningful workflows across your organization. So when your organization joins the collective network, or if you have interest, if you're not on the network yet, our application specialists work together to help you to generate an Excel spreadsheet to surface your active patient population. Once this Excel spreadsheet is generated, each organization can either choose to manually upload it through the portal, or we can help you to stand up an SFTP. Once those files come to the collective database, those are the patients that you will be seeing in your web-based portal. It is critical for this eligibility file to be coming in a consistent format on a regular cadence, because your team's ability to case manage and care coordinate your various populations is dependent on being able to see them on that file. So many EHRs have the functionality to pull the needed data from collective medical, just like you pull for your health plan metric reporting. So we are happy to help you to get that stood up in the most automated fashion possible. So then that way, again, the file can come and be submitted to collective medical on a consistent basis. We would recommend every 2 weeks, but if your population doesn't change that much in a month, then once a month should be sufficient. The eligibility file itself, again, is intended to give us the patient information that helps us with the matching. We also look to have additional columns or elements that might be important to you for your care coordination, case management, and program outcome tracking. So as we move forward into the demonstration, I will talk some about the tag opportunity. And tagging a patient is your way from your file to say this individual is in a specific care pathway, or they are receiving specific case management services. So then that way, our portal can help you to sort those populations in a meaningful way and get data back on how your initiatives for transitions of care and outreach are going in the space of reducing potentially avoidable emergency department visits. So once you've given us your patient population, our job is to get you back the information in meaningful buckets to be able to deploy your workflows. We call those buckets cohorts and criteria. So the cohorts page is the page that enables your teams to identify patients with quote unquote visits of interest. And those visits of interest can have to do with patterns of high utilization, such as this individual has had 5 emergency room visits in the last 12 months, or a visit of interest could be that this individual has had a safety and security event somewhere on the network. The intent of the cohorts page is to help you to identify individuals who might need case management or care coordination based on the criteria that is in your portal and the initiatives that your organization is running. While the cohorts, again, surface the risk population, criteria of interest, we also make you an overall census. So this overall census is intended to give you the opportunity to look at all acute encounters, skilled nursing facility encounters in the last 72 hours. This excludes risk and can be an individual who has no patterns of high utilization, but perhaps they had a planned total hip replacement. You knew they were supposed to check in for admission on, the 26th. Well, the census is an opportunity for you to quickly verify that the patient you were expecting to go for surgery has actually arrived. Additionally, we created filters for you. So if you are specifically collaborating with facilities in your region, or you are only doing follow-ups associated with specific hospitals, you can now filter and sort this information so you can see all of your clients or members that have gone to a specific hospital or skilled nursing facility. This information of both cohorts and census can be pivoted to scheduled reports. So a scheduled report is an opportunity where Collective Medical can put in Excel reporting into your web-based portal from the data across our network. We can also de-identify this information. So if you have been using staff time or panel coordinators' time to be de-identifying reports to get it over to your quality team, Collective Medical can actually take care of that and do that for you within the portal environment. And so these can be set up on a cadence of whatever you say. And again, they come down in a CSV or an Excel spreadsheet. So then that way you can take this data and put it back into your other programs for which you do your overall reporting and program analytics. I personally was a customer of Collective Medical at an organization called Northwest Primary Care here in Portland, Oregon, where I live, before I joined Collective Medical as an employee. We leveraged scheduled reports heavily, both across our business office as well as my care coordination team, because it gave us the opportunity to do strategic initiatives based on the reasons our patients were going to acute care when they could have come to us. So a scheduled report can be valuable across both the care providers as well as your business needs, and hopefully save your staff time and resource for those items such as scrubbing PHI. We have a report builder form that is available to you through our support at Collective Medical. And as you can see, you as the customer define both what patient demographics come over as well as the event type. And of course, what type of look back windows or frequency you want. So again, if this is something that you aren't leveraging and have interest in doing so, all you would have to do is reach out to support and ask for the report builder form, take it to your team and decide, could some of these reports save your organization time? With that, the tips and tricks are when you get the reports, if they're valuable, please use them. But if you find that you've made reports because it looks like a really great idea, but you don't end up using them, you don't have to keep having them. Collective Medical wants to help your portal be as clean and succinct as possible. So feel free to let us know and give feedback on what it is you're trying to achieve with a scheduled report, whether it be a work list for care coordination, or perhaps you're trying to do looking at access and access hours for folks to come to clinic to avoid ED encounters. Additionally, the final thing before I move over to the demo environment that I wanted to surface is that, as I'd indicated earlier, it is absolutely the customer's choice, dependent on workflows, if you receive notifications at all. But while you're thinking about that opportunity and your workflows that could be enhanced with it, it's also important to know that we have built-in reporting within the platform for supervisors and managers to have visibility into how many email, text, or faxed notifications came through and to who they have gone to. So thinking of the space of you might have multiple physical locations and you're trying to supervise and support your teams across the continuum, this creates the opportunity to be able to assess the influence. Was the real-time notification received, followed up on, and what was the outcome? So again, this is just a little nugget within the platform of organizational tracking for you. So as you make decisions on how you might want to engage deeper with the collective network, there are tools for you to be able to see the changes made as well as get reporting on that information. I'm going to pause before I go into global flags because insofar, everything I've discussed has been about your organization sharing data in a HIPAA compliant way with Collective Medical for us to share your patient's information and utilization back. The next section, I'm going to be talking about data from outside of your organization that we move into the collective network. But I wanted to check with you if there were any questions, comments, or concerns before I moved into data that comes from outside.
Hi,
Yes,
Kate,
I have
this
a
is
question.
Brittany.
Oh,
It
go
looks
ahead,
like
Brittany.
there's a couple of questions in the chat. One is Sonia said that there's why when we get a notification, is there rarely a chief complaint listed? And then Sarah from Lords also had one that asked if you could expand a little bit on the SFTP.
Absolutely. So first question, oh man. Collective Medical works really hard with all of our hospital customers across the 43 states to keep clean data feeds coming into our network. Every hospital is different, and as we all know, since the pandemic, there have all of the hospitals in America. So with that, we are aware that some hospitals might struggle to consistently be pushing the ICD-10s from their feeds to our portal. We absolutely welcome you to send a note to support if you have identified a particular area where you are not seeing the chief complaint. Because what that tells me is that while we're getting the feed, we're getting the patient demographic, there is a problem with the data we're getting from that hospital customer that the ICD-10 is not carrying over, and we would be more than happy to reach out to that hospital and offer assistance with that. So anytime you are missing an ICD-10 on any encounter you see, it comes down to the data that we are receiving. Collective Medical has a tickler system and a process for data feed reviews. And so we do work hard, and our hospitals do want them clean and good data coming across. But having compassion for all that's gone on in the last year, we are aware that there have been a couple struggles on that one. As it relates to the SFTP, Collective Medical can actually credential with your department that if you have a path for SFTP, we can get you the credentials on our side to have that eligibility file just pulled out of your organization's housing of the file and pulled into our system. What that requires is that whoever does the eligibility file at your organization, we just need them to reach out to support to say they're interested in standing up an SFTP, and we will have one of our specialists get on the phone with your team, and then, forgive me, I'm a social worker, so I'm just going to say it like this, then they'll give each other like special numbers and letters and codes that will then create a bridge. So then that way, Collective Database will just come over and pick up that eligibility file from your organization and put it in our database and avoid your teams manually having to upload it there. Did that help?
Sarah said yes in the chat. That helped.
Awesome. Thank you. Okay.
So we have a few
And
more
of note-
questions on the chat as well, whenever you get a moment.
Oh, please. Yeah. And I'm sorry if I'm hurting your eyes. I just like to jump to the slide first. So I can always reference the picture. So please, what's the next question?
So what other types of organizations use collective medical, i.e. like skilled nursing, rehab, EMS, dental, etc.? And can you give some examples of how they might use that?
Absolutely. So Collective Medical is a mission-driven organization, and our goal is to support providers in collaborating care in real time. So any organization that has a HIPAA relationship to the patient can join the collective network. At this point in time, dental providers have not been joining the network directly for the purpose of leveraging the technology I'm showing today, but through the MCOs and health plans are working on getting dental provider data onto our network that the MCOs and health plans are helping by surfacing that information. As it relates to skilled nursing facilities, I'm going to call out Prestige because I see them here, and skilled nursing facilities are absolutely leveraging this technology for the opportunity both to have meaningful transitions of care where they can see the entire care team associated to the patient that they're receiving, but also they are able to receive notifications in a 30-day window after their patient have discharged. So what that allows for is that if an individual is clinically appropriate to be reskilled, Collective Medical basically sends an alert to the skilled nursing facilities to say, your patient discharged, this resident discharged from your facility in the last 30 days, and they're over at Cadillac. That will then allow for the hospital liaisons from the skilled nursing facilities to reach out to the case managers to offer that if it's clinically appropriate to reskill that patient and avoid a readmission, that skilled nursing facility is working on bed availability and creates the opportunity to foster collaboration to, again, meet that patient's need in real time. And if clinically indicated, reskill them as opposed to having them readmit. Home health entities are using us multiple ways. One of the things that they're doing is just trying to surface for the care continuum. Hey, we're affiliated with this patient. We are in their home providing skilled care. So then that way, if you as a PCP, are needing to collaborate, you have that visibility. Additionally, as we look at the struggles of home health in the rural space, nursing shortage, all of these things, our network is providing value that when they are actually deploying to a patient's home who just went to the emergency room, we're sending the home health nurses texts. So then that way they know not to continue driving the next hour to get out to that patient's house because they're in the emergency department, which then is allowing for them to see more patients as well as to collaborate with the emergency department in those situations where they feel that they can manage the patient with the skilled home health. And again, potentially avoid a readmission because the services are there in the home environment. We also are able to bring on some EMS services, and the EMS services have to have a defined HIPAA relationship for us to do so. So thinking of looking at the region of the Tacoma area, there's a robust care coordination program done through the fire and EMS there. And so they're able to furnish Collective Medical with an eligibility file of individuals that they do EMS community care for. And then we're able to give those EMS providers that information just like you get through a web-based portal and real-time notifications. Of note, Collective does not have an offering for 911 first responders because, again, there has to be a defined HIPAA relationship in advance for us to be able to collect the patient data for matching purposes. So I get super excited answering that question, and so I'm going to pause because I'm afraid I'm getting on a soapbox. But basically, if they are involved in patient care and they have a defined HIPAA relationship, Collective Medical is eager to help bring them onto the network.
Thank you, Kate. This is Martin with Greater Columbia. There's another question here in the chat from Sherry Greenland. And the question is, how do you get a hold of Collective Medical support?
How do we get a hold of Collective Medical support?
Correct.
Yes, okay. So first it's support@collectivemedical.com, and that is our email. And that goes directly into the queue. We have support employees in every time zone now, so that is the primary way to do it. When I get into the demonstration, I will also show you that within your web-based portal on the bottom left-hand side, we have a support tab. So you can always email through your portal, and in your portal, there's a phone number for the support line. So if you feel like you've been waiting, or perhaps you need something right now, in the portal environment, there's a phone number for your region that also goes to the support team.
Thank you, Kate. I appreciate your answer on that. This is Laurel from Greater Columbia, and Demita Warren has a question in regards to how can we determine who our sponsor is for signing up for Collective Medical?
We're happy to help take care of that for you. So what we do is we just ask you to reach out to the support@collectivemedical.com. Then from there, it will be kicked over. Once they queue it up, they will send you a discovery form just to get some basic information about your organization. And within that discovery form, we do ask you to call out some of your health plan relationships. And then that discovery form will go over to our implementation team. And as indicated, Erica Anderson, as the customer success for the health plan, will then reach out to the health plans that you work with, and we will find you a sponsor. Because again, the MCOs of Washington are absolutely eager to see collaboration here, and we're more than happy to help identify that sponsorship on your behalf.
Great, thank you. And then we have a couple more questions, and then I think we'll probably move on for your demo. I have one from Dr. Taylor, and he's asking, do we have any prospect of the Collective Medical report to include the ESI, which is the Emergency Severity Index score, for discharge from the ER?
That is an excellent question. I'm taking a note on that, and the answer is right now, no. And that has to do with the feed that we get from the hospital. And quite frankly, I'm not sure that's a data element we've requested, but I love that. So I will take that back to my product team. And so it's a no, we don't now, but I absolutely love that. And I'm going to talk with my team about opportunities to see if that would be something available to pull down from ADTs that we have with our hospital customers.
And our last question for right now, and we also have a comment. And the question is, just one second here. Is there an API we can tap into for integration purposes from Garen Barnett?
Excellent question. That is something that I would also have to, I would need to take back to the team. And the reason being is that Collective Medical is a high trust certified organization. So the process as it relates to building off of APIs does require a couple levels of security checking. And so our security department is who primarily does that vetting process. But we are more than happy to scope and do a discovery call with your organization on what you would like to do there, and then connect the security teams to go through that process of assurances, just because, again, The building off the APIs does relate to some high trust security requirements Collective has on our side when customers are looking for integrations like that. But we definitely are in the ballpark of whatever we can do to help you engage and get the data you need. We're interested in finding out the best path for that. It just might take a couple calls of discovery.
Sarah made a comment on that. Thank you, Kate. We have requested this information in the past. It is a wonderful tracking tool.
Awesome.
Okay, and at this time, we'll go ahead and move on with the presentation. Thank you again, Kate, for all those questions.
Oh,
Great
yeah.
answers.
Yeah, thank you guys so much. And I'll pick up my pace because I'm looking at the time now. And please know, everyone, that these materials will be shared. And I have the links here to all of the training materials in your current portal about the details that I've gone over today. So moving up my steps a little bit, I'm going to talk about global flags. So sometimes you may see on your patient overview page a big colorful box that has another box around it. This information is called a global flag, meaning the data has come from outside of your organization, but is about a patient you share. Every global flag has a hover bubble. And here you can see an example of the St. Joseph Providence Health System shares all of their COVID-19 lab data with us. And if and when a patient has a positive COVID lab, we will tie it onto the patient information for you to see. Additionally, within Oregon, there is a specific initiative and metric at the Oregon Health Authority around individuals living with serious and persistent mental illness who are known to be high utilizing acute services. So a flag that you might see that comes from another state is telling you that this individual is a denominator population and a metric from another state, and should be helpful to get you the details about them so you can then look at the care team to see how you can best serve that patient and getting connected back to care in their region. So this is the time that I'm going to now switch over to the demo environment. So then that way I can show you what these things look like. As indicated, every customer has a web-based portal. And once you put in your credentials, and mine is a demo environment, so here we go. Once you put in your credentials, you land on the cohorts page. So this page is telling me my file is in the collective system, and in the time frame defined here, this is how many of my patients met a specific risk criteria. If I don't need to look into the risk criteria, I wanted to see the census, I can pull the sidebar. And the risk criteria, the census, the scheduled reports, they're all right here for me. If I needed to get into my patient information, I could click their name, or I can put their name in the search bar. And once I search my patient, it will come up with their information on one page. So those users who receive a text or an email notification, when they click the hyperlink, they're going to land right on the patient page. Those who log into the website will come into the cohorts page. I'm going to go through the details on this patient page to make sure everybody understands all of the data that's available to you. So the first thing we see is that this individual had a safety and security event at another facility, and we timestamp this information and share it, so then that way, again, patient safety, staff safety is the top priority. The next section we see is the demographic information as we received on your eligibility file or for the skilled nursing facilities from their feeds. Everything that says view more is your access to the details from the collective network. So knowing that Washington has been live longer than anywhere else in the country, you guys have robust data on addresses and phone numbers on individuals, which creates the opportunity to have conversations perhaps around housing insecurity or transportation in a different way, because you have more details about where the patient has been. The area down here where it says tags is the opportunity where, again, on your eligibility file or even in your portal, you can manually add the programs that your patients are participating in. This allows for any member of your organization to log in and quickly say, oh, yep, they're in our anticoagulation program and they are in our COPD program. This then allows for the collective platform to track all these tagged patients in a sidebar called groups. So whoever the supervisor or manager is of each of these can have a list of all of their program participants in one place. This is also where you would see the global flags. Again, the global flags have a big box around them, and will always have a hover bubble for greater detail. The care team information is populated from NPIs and taxonomy codes added to the eligibility files and received from feeds. This is your opportunity to both identify who is an active care provider with a HIPAA relationship and see how Collective Medical got that data. This is also super valuable in the space of perhaps you have a new patient and a new client and you're trying to, start a new relationship. Well, you can see their inactive relationships as well. So in the space of perhaps we've had some insurance change, things of that, this can give you more information about who that individual has been seeing. The encounter history section is where we aggregate all of the data feeds into one place for you to see. It's defaulted at a 3-month look back, but once you're in portal view, you can look back as far as 12 months, or using my example of, I knew Mary was going for a total HIP. Did she actually make it there? You can do a date range search too now, so you can see the encounters associated to the range important to you. If your role, perhaps maybe, you're doing panel management, you can also do major types. So thinking of individuals in the skilled nursing facility arena, one individual could potentially stay at multiple skilled nursing facilities over their 100-day benefit. So this creates the opportunities that you can meaningfully look back and know where was this patient and with their actual admissions and discharges. Because each date within this field will pull down the details from, in this example, the inpatient hospital EHR to show you the diagnosis, as well as the discharge disposition and timestamp when they actually left. There's another tab, please.
Sorry, there's a question in the chat. That says, how would we edit the provider information provided by the MCO, i.e. after a staff has left our agency but continues to show up on collective medical alerts?
So it's your staff, not at your organization, and the MCO is submitting that care team information. Is that correct?
Sounds like it. Yeah, okay. Thanks,
okay. So please feel free to reach out to Erica Anderson. She is the health plan success manager, and she's more than happy because she regularly meets with all the plans that we can certainly help surface that information and ask that their NPI be removed off their eligibility file. And if it's easier that you have my email because I'm on this invite, you feel free to email me and I'll get it to Erica Anderson. So then the next section after the encounter history is the care guideline. So this is an opportunity for individuals with the longitudinal relationships with the patients to share recommendations for the emergency department. As I'd indicated, the emergency rooms can see these guidelines before they actually see the patient. So we ask you to pretend you've got 60 to 90 seconds to talk to the emergency room team about your patient and share meaningful information that will be actionable when your patient is there. So this information is viewable by all those on our network with a HIPAA relationship with the patient, and each part of the care continuum can also create their own. Of note, in the state of Washington, there was wonderful work collaboratively across the ACHs to create a toolkit just on how to use and share information with this mechanism. And so we're happy to ensure that you guys have access to that training tool, as the Greater Columbia absolutely helps create that, those documents as well. The safety and security events, as indicated, can be added here within the portal. And then finally, you have the opportunity to upload attachments. So this is an opportunity where if you have guardianship, conservatorship, perhaps you have a narcotic contract that you can share with the care continuum. We ask that you upload it here. So then that way, if and when your patient presents for care, everybody knows who the legal responsibility for decision making is, as well as if they are perhaps in an opioid reduction program, the emergency department would love to support your initiative if they know that that is what's going on with this individual. And so they really value those types of documents because it changes the way they can have conversations with patients when they actually have the tools from the downstream providers. So that is my quick review of the actual functionality, the details within the patient overview page. So I'm going to check for one last time for questions and comments, because I believe my next section is just about how do we get the support information, which I believe came up a little bit earlier.
Kate, I'm not seeing any in the chat box, but if anyone has to verbalize any questions, go ahead now.
Okay, great. So 2 more slides, and that is just to say our support team is not only here to help you, but we also want to help you with your tracking and record keeping as well. So please know your organization can be trained as an account manager to add and remove your own users. If you would like Collective Medical to add and remove your users for you, we've got a form, and our form identifies each of the key roles. So you are always welcome to ask for this form if you would like for us to be adding and removing folks, or let us know and we can train you on how to add and remove them yourself. Additionally, we have forms for you that if you do want to set up notifications for text, email, or fax, again, this way you have track records for your organization of what requests you've made. And then that way, again, you always have the tool that if you have incoming staff, etc., you can just send this over to support. And then finally, we learned this was a recommendation actually by an ACT team, and that was that they had decided within their organization they were going to make a collective medical support template. So for their organization, they literally have a specific template that has been approved by their organization. So then that way, the leadership of that BH program always could track exactly who was asking for what from Collective Medical in the same exact format. And they found that it was tremendously beneficial to them. So we just wanted to share with you that if it is easier or better, again, for your team management and compliance and alignment with your privacy officers and policies and procedures, that we always would welcome that if you had a templated version for your support requests, we're happy to work with you, again, to stay within alignment with your policies and procedures. And that is all I had. So I'll stop sharing the screen and think we might be back on time.
Okay, so I'll go back to sharing my screen. We were just going to close out this section with offering up more opportunity to just ask any open questions to Kate. You guys did great asking questions throughout, but any other lingering questions?
And if there's not, I think I want to expand a little bit back on the whole collective medical would like to support onboarding to any of your providers that you collaborate with, right? Like the goal here is to be able to help you in whole person care. And so if you know that there is a trusted community partner, perhaps it's a program, like just let us know. And we would be happy to talk to them, do discovery around their HIPAA relationships to help them onboard. And now that I'm not screen sharing, I can see the chat. So these are great questions, Celeste. Thank you for asking them. So how long a patient stays in the portal depends on your part of the care continuum. So hospitals or acute care customers, their relationship to a patient is 12 months from the last visit. The reason being is that when we look at HIPAA, HIPAA is basically defining the terms, because if they haven't seen that patient in that window, they don't need to see that patient's information. So if that patient has been seen in the last 12 months, you will be able to see them in a hospital portal. If you have not seen them in the last 12 months, they will disappear. Meaning, if you search in your web-based hospital portal for that patient's name, they are not going to come up. As it relates to anybody who joins the network on a file, those patients will be viewable within their portal as long as the patient is on the file. So that's why when I was indicating if you have a lot of population change, you know, maybe once a month to submit the, if you don't have your population change for your clinic, you don't have to, could you not hear me? Did you lose me?
I can hear you.
Okay, sorry. So if, okay, thank you. So if the patient, like let's say the patient was assigned to you through delegation and they have changed their health plan, so now they're assigned to a different clinic, you want to get that patient off your clinic file as soon as possible. So that's why the cadence of the file is so important, is that if you're getting new patients in and out all the time, we want to be able to keep you seeing only who you have the HIPAA relationships with. So looking at a health plan, if an individual has signed up for a specific health plan, let's say a Med Advantage plan, and they've been on that plan for years, they are going to be visible in that health plan's collective portal as long as they are an active member of that health plan. So it really does come down to what part of the care continuum you're in and when they drop off. Skilled nursing facilities, as I'd indicated, they have, because of HIPAA and on the treatment, payment, and operational side, they have a 30-day window to potentially reskill. And so skilled nursing facilities can only see the residents who have discharged for 30 days. So on the 31st day, collective medical basically makes that information invisible to their portal, again, to protect that patient's information as well as the facility, because these patient attributions and visibility are all designed to be in alignment with HIPAA. And again, we do a lot of discovery on the front end about the different treatment, payment, and operational relationships organizations have through our discovery form and discovery process. So lots of words there, but it does vary depending on who you are.
Okay, thanks, Kate. Any other questions for Kate? Let's see, how do we see the list of patients you currently have?
So the way it works, so that's a tricky one. So the list of patients your organization currently has would be on the eligibility file. So if you are a clinic, a BH, or a program, the file is the source of truth, and that is the full list. We at Collective Medical, because we are high trust, and the way we treat patient data is sacred. So your files actually go into a salt hash encryption in our database. So Collective Medical is never actually looking at your patient information. It's just we are querying the database and reflecting back to you. So Collective Medical doesn't really have an ability to say to you, hey, customer, these are all the human beings in our network, because with our high trust certification and treating PHI as sacred, it's all in ones and zeros for the patient's protection. So again, the file is the source of truth. So whoever builds your file is who would have the current list. And certainly I'm seeing here that you want to upload daily. So what we would do is I would actually ask you, Karen, to probably just put in a support ticket, because I keep saying go to support, but they have a ticketing process. And what they do is triage and connect you to the next right person. So what we may want to do is have you go to support. We'll get someone on the phone with you. We'll look at your current, I just would like a notification if it fails. So you already do it on a daily, but you're not getting notifications if your file fails. Noted. Okay. So I'm taking a note on that because absolutely we have a tickler system from that, and what I'm hearing is that is not working for you. So we would be happy to follow up on that for you. Okay, so the next one is the diagnosis keep building or go every time they go to the ER, or is it just for that visit? It is 100% just for that visit. And our actual final column on our web-based portal says chief complaint or diagnosis. So the reason for that is that because it is real time, the first ICD-10s we receive are usually the chief complaint that triage enters. As the emergency room team works their differential, once they change the ICD-10s in their EHR, the collective network will pull that up and refresh your portal. So that means you may get a notification for chest pain, but give it 15 minutes and you're going to see CHF. So it builds on itself for that encounter, but it is a unique encounter from the previous. So our system cannot and does not look back and say, their last visit was for a stroke, this visit's for chest pain. It is just this one encounter they're experiencing right now, but you can see multiple ICD-10s when the feed is consistent, giving us updated messages as they work that patient up.
Looks like there was follow-up clarification to that one. So if the chief complaint is NA, we can go with the diagnosis as the reason for the encounter.
That actually feels like a data feed issue like earlier. So the chief complaint shouldn't be NA, right? It should really have an ICD-10 in there for you. So if you're not seeing one, please feel free to let us know, not on this call because we don't want to call anyone out in particular, but that tells me that there's a feed problem because you should certainly be seeing ICD-10s from the time you get your first notification.
Okay. I think we do have, if there's any more questions,
Actually, I
can
think
take
we're
them.
ready to go ahead and wrap up. This is Laurel.
Okay.
So we are so appreciative for all that information, Kate. Oh my goodness, thank you so much. I know a lot of the sites I work with, we've had questions, and a lot of the things that you've covered so well have really answered some of those questions. So just want to thank you so much.
So grateful for the opportunity to be here, and please don't be shy, everyone. If reach out if I can be of further assistance, and of course the team here knows how to reach me as well. So thank you.
Will you be on for the rest of the presentations?
Yes, please.
Okay, thank you.
I love this.
We
Fantastic.
yeah. Thank you.
Okay.
At this point, we'll go ahead and move on.
We're going to go into our section of our partnering provider presentations.
So this is Laurel again. I am so excited to be able to introduce Hannah Tower. She works with Comprehensive Healthcare in Ellensburg. Hannah has worked for Comprehensive for 13 years. She started as a nursing assistant in one of the residential facilities and eventually transitioning to a residential counselor position there and worked at Glede for 6 years. After a few years, she moved to the outpatient world and began on the Yakima rehab team, providing case management services for about 3 years before transferring to the Ellensburg site. Hannah continued with case management on the geriatric rehab team until June of this year when she completed her first year of her MSW. She now works as a therapist trainee on the brief intermediate team, providing outpatient therapy as well as school-based therapy services at Easton, Thorpe, and Kittitas school districts. So I would like to welcome Hannah and turn it over to her for the next few slides.
Hannah, it looks like you're off mute, but I actually can't hear you.
Hello, hello.
There we go.
Okay, coming through now.
Sweet. Yeah, I'm actually out at Kittitas today, so that's why I have my mask on. Anyway, Comprehensive's mission is to provide innovative, integrated healthcare, community education, and services to individuals, families, and organizations. And that's what it is on behalf. I love our mission statement, and I've seen it throughout different sites I've worked for. I'm at Comprehensive. So,
Hannah, it might help. You're a little bit choppy. It might help your audio come through if your video's not on. I do love and appreciate seeing your face.
okay.
But it might just be better for audio if you turn that off. Thank you.
Yep. Okay. Awesome. No problem. All right. So Kittitas County covers not just Ellensburg, of course, but we have Cle Elum, and we go all through. Yeah, I was gonna say there that zooms in a little better, so we get all of our little sites that often get left out. So that's why we've got Thorpe in there, which is one of our schools that I go out to, and we also have a school therapist at the Cle Elum Roslyn School District as well, and we have an office at Cle Elum as well. So and our DCR services, our crisis services, cover anywhere in Kittitas County. So anytime there's a crisis and you're in any of those towns, where you're covered, you're totally covered. So we can skip that slide. Ellensburg, our 4th Ave building, where most of our services are provided at. We have a variety of services there. We offer some housing. Sorry, my brain is just done. It's Friday. It's transitional housing. We have 10 individual apartment units, and then we also have a triplex, 2 different triplexes, and then our Aspen domestic violence shelter. A part of the apartment complex, we also have a crisis unit. And all of these housing units are obtained with or can be accessed through being a client of Comprehensive and being engaged in our services. And again, they're transitional with the goal of 2 years, being in them 2 years. And so as soon as we determine that it's an appropriate fit, then we start working on getting you on housing lists for subsidized housing within the community. We have outpatient teams. So like I said, I used to be on the geriatric rehab team, and that's for our long-term clients, but now I'm on the brief intermediate team. Between both the teams, the outpatient teams, there's 22 clinicians. We have 2 medical staff. So that's our ARNP nurse practitioner that does the medication, that prescribes medication. And then we have her nurse. Then we also have the Aspen services staff. So there's 5 staff there. And then we also have the WISE team as well. So the wraparound services. And then we have support staff and facilities, and we're actually, let's see, we're at 4. I always forget, we're at 4 support staff right now, and then the facilities staff. So we all wear multiple hats usually. So I talked about the transitional housing. Most of our, both on the rehab team and the brief intermediate team, most of our therapists are also DCR, so the designated crisis responders. Most of them play both roles. So we have 24-hour crisis services. We also have, now we have a partnership with KCHN for services at the Kittitas County Correction Center for jail-based, the MAP partnership, and as well as we just now have the jail-based therapist full-time there as well. I used to also provide services at the jail, but now that we have that full-time therapist position there, we have coverage there full-time, and I was only able to do the part-time services, so it's kind of cool that we have that up and running full-time. And we also are going to have the MAT partnership there as well with a nurse position there as well for the MAT services. And then we also recently are starting up the MAT services for outpatient. I already mentioned the WISE program. We also have the Hub and Spoke program. Of course, I said that we have the medication management, which means that covers psychiatric evaluations, Aspen and the domestic violence shelter, and then part of the SUD services. We also have she does our individual and group SUD services. What else? I think I got everything on the list there. And then, we're very focused on the evidence-based programs for therapy. I am just about certified in CPT. I think I have one more client I need to get through. I just got one completed. I'm also using DBT with several clients, And next week I actually get trained in CBT plus, so that's exciting. We have several different group therapies that we provide. We have illness management and recovery, depression group, and DBT. So we're very busy. Quote, small site. Doesn't seem so small.
Yeah, it's such a nice thing. We really like to have, it helps to have you describe. We like all of our partnering providers to know a little bit more about each other. So we're trying to have an emphasis on providing that background during these learning collaboratives. We'll go ahead and go to the next slide, please. Okay. So basically what we're going to do, Hannah and I here, is just do a little bit of question and answer. I just wanted to, Hannah's been doing a great job following up with the collective medical alerts for the Ellensburg site of comprehensive healthcare. So Hannah, if you could, and Stacy has your spreadsheet available. So when you're ready, if you could describe the process you use when you receive and follow up on the collective medical alerts.
Okay, yeah, so my kind of simple process for just checking up on the collective medical stuff is, one of the first things I do when I start my day is I check my email, and the first thing I see in my email usually is an email labeled as support@collectivemedical.com, report complete. I click on that, I log in, and of course, I'm not going to know all of our clients. So I scroll over to the address column, and if they're in Ellensburg, if they have an address of Ellensburg or Cle Elum, then I'll look up the clients in our EHR and then see who their assigned primary clinician is. And then I will then send that clinician an email. And then I will CC both Kittitas team leaders, the site director, and then we also have a crisis case manager now, and include her as well. And then I'll pull up my little spreadsheet here, type in the clinician, so the primary clinician, the date that I notified them, the client initials, and then the 7-day date to follow up, and then track that. Once I get an email back, I will track whether or not I received follow-up via email from that primary and or like the crisis case manager in my little spreadsheet. And so far it's been pretty effective, just for making sure that I have some kind of tracking system. Yeah, and it for most days, it goes pretty smooth.
About how much time is that taking up for you, Hannah, when you start out? You said you do it daily, so like how?
Yeah. Most days it's only really about 30 minutes. So right now, because of my schedule and everything I'm doing, my Mondays are actually Tuesdays because I'm working 410. So I have to do Saturday, Sunday, Monday. So when I have the Tuesdays, when I have the 3 or 4 days to do at once, that can take up to 90 minutes, but most of the time it's only 30 minutes to do that.
Awesome. And then I wanted to ask you if you could share a story with us about the impact it's had on one of your patients. Of course, keeping that patient anonymous, but if you had a story to share with us.
Yeah, actually, I had a client who was being treated for cancer and was getting services in Yakima for her cancer treatment. And I was doing my regular login, check the collective medical report, and I saw her name and pop up on there and saw that she was at or that she had been in Virginia Mason Memorial in Yakima. And so I did my follow-up. I called her and I was like, hey, what's going on? How come you were in the ER? And she was like, huh? How did you know this? So I explained all of that. And then she informed me that she ended up having a reaction to the chemo treatment. And was supposed to be her second to last chemo treatment, and she didn't even she didn't think that it was even relevant to talk to me about. And I explained that actually, you know, medical is, you know, very directly related to your mental health. And then she went on to tell me that she was glad that she talked to me about it, because she had in fact decided to make that her last treatment because her reaction was so severe. And yeah, it was really neat to see how that directly impacted her treatment with us, and her, you know, knowing that, especially since it was an out-of-town hospital too. It was just really cool having that information and having that a part of the care that we provide.
You know, I know it's just one of those things that we've been working on, changing the culture from being so siloed with mental health and physical health. And, you know, having the ability to get those alerts from across our care continuum and be able to talk with patients. That conversation that you had helped her understand the involvement of your physical health and your mental health, which is what you covered, and to come alongside and really help the whole person. So I love that story, Hannah, and I just appreciate so much that, you know, you're providing care in that way, and have learned so much about it. And I love hearing about the patient that was the person, you know, that was helped holistically. So thank you so much for sharing.
Yeah, and I have to add, she's cancer free now, so.
Yay. Okay, so, and then I see a question in the chat for us in regards to, is there a uniform way that the information is communicated back to the clinician, or like a shared care plan there at Comprehensive?
What I do is I'll just tell them all the information I get when I, you know, log into the report. Is I will send an email, hey Dave or whoever, your client bank was seen in the ED for, and then whatever the reason is, please follow up within and let me know what you have.
Okay, so Hannah's breaking up, and hopefully you all can hear me clearly. What I heard her saying was what she's doing is really emailing the client and provide the clinician and providing the client information in regards to the alerts, the collective medical alerts. But what she didn't share, Hannah, I don't know, do you use that section that says insights for care in collective medical, or is that, is there a way that that information is shared? I think that's Sam's question to get that. Is there a care plan or care action plan that's shared back? Is that right, Sam?
That is correct. Thank you, Laurel.
Mm-hmm. And so that's for you, Hannah. Is there a shared care plan as part of that communication, or no? And it's okay either way. You're doing great work. We're just curious.
Not specifically, like if there's a client that is like new, because sometimes, you know, it's clients that I also know, and it's just a client that goes to the ED frequently, and we know that they already have a PCP, and they're just high utilizers of the ED. Then it's just a typical kind of check-in. If it's a newer client, it's sometimes there's a reminder to, okay, make sure they've established PP. Sometimes there's clients that, you know, a client that has specific health things going on, and not specifically, I don't know, but if there's conversations between clinicians and their team leaders, hasn't been my directive to line out to give instructions of what the conversations are. But when like a new clinician gets one of those emails that hasn't received one, and it's something like, oh, the client went to the ED for I'll watch everyone for like, there's like a personal medical thing. And they're like, you want to follow up with this? And I said, yeah, sometimes it's just making sure that they have an ECP, or because they're clinician with client don't typically go. So sometimes it's just providing a little bit of info for them, because they don't know how to address their clients.
Okay. So Hannah was breaking up quite a bit. I'm going to quick summarize what I think I heard her saying, and being familiar, because Hannah and I get to talk pretty often. So what she's saying is she's using the email pretty much, and if there's anything, because it's a known client that she needs to share with that clinician, and maybe it's a new clinician, she'll include it, but they're not really using the Care Insight part of collective medical. But she is using the opportunity to incorporate physical health whenever possible to help move the clinicians towards thinking holistically for patients. So if she's had questions coming back from the clinicians like, hey, this is not a diagnosis that's, mental health or substance use disorder. So, do you really want me to ask or know about this? And Hannah's covering that information with her clinicians that she's alerting, and kind of helping them get the understanding of the integration of physical and mental health. So I hope you heard me, Hannah. Was that okay?
Yeah, that was perfect. Yep, that was perfect. Yep. Okay. Yep.
All right. If there's any specific questions, okay. And there was a comment. That is what we also do here from Sonia Mahaney, and send out the information to the supervisor and the main clinician to set up a care plan. So thank you for that, Sonia. And I want to keep us on track here. So I'm going to go ahead and let Brittany take over to introduce Sarah. I want to, before we do that, thank you so much, Hannah. I appreciate you taking time out of your busy day. We appreciate you.
It'll be me, Laurel, sorry. This is Martin. So next, I want to introduce Sarah Cashman. She is a nurse, an RN nurse navigator there at Lourdes Health. She is originally from Olympia. She moved to Richland, where she graduated from WSU Tri-Cities College of Nursing, magna cum laude, in December 2015. Sarah joined the Lourdes Health team and worked on the medical surgical floor at Lourdes from February 2016 to February 2020. In March, she became an RN navigator at Lourdes Physicians Clinics as part of the Practice Transformation Project. In her personal life, Sarah is a mom of a 4-year-old daughter named Luna. She has 3 dogs, 2 Airedales named Charlie and Russell, and an Australian cattle dog named Esi. Sarah likes to sew, cross stitch, crochet, bake, and go for walks. And please join me in welcoming Sarah to be our next presenter on how they are utilizing collective medical.
How about now?
We can hear you.
Okay. So I was hoping I could share my screen. I'm not sure.
You should be able to.
Oh, there it is. Okay. Can you guys see this really complex looking Excel spreadsheet?
Yes.
So when Martin approached me to talk about my use of collective medical, he asked me several specific questions. And the first one is, how do I receive the alerts? And I actually log in to collective medical every day and pull the report, and then I add it every day to this master list. Well, I should probably back up. I work in primary care. So I work at Lourdes Primary Care and Internal Medicine and Lourdes Family Practice in Pasco, Washington. And so I'm following up on patients when they discharge from the ER or inpatient. And so I get these reports from collective medical every day, and I have 1 page for ER and 1 page for inpatient. And all of the columns in purple are information that I pull from collective medical. I've blacked out the patient's MRN name and date of birth for privacy reasons, but this is my actual list from August of this year. I add in some other things as I'm doing the review. I add in who the PCP is, and they're always with my clinic. I add in whether or not they've been contacted, and I use a lot of color coding systems because that's how my brain works. And so most of the time patients do get contacted within 7 business days of their discharge. The discharge column or diagnosis column usually is filled out by collective medical, but there are times when it's blank. And so when I do chart review to follow up on that ER visit, I find it and add it in there. And the color coding here is the brown is patients that have more than 1 visit that month for the ER, and then the blue is COVID related because everybody seems to be. This next column is a 12-month rolling ED count, counting the most recent visit. I keep track of this as well and highlight folks in red if they've had more than 10 ER visits in the last 12 months. Gray is that for some reason they're not on our collective medical roster, or the visit was missing, and then I put in a support ticket at the end of the month and find out why. And usually it's because they're a brand new patient of ours and they haven't been put on our roster yet, and so we'll upload a new roster and get them the next time. This is the date and time I call them, when they have a follow-up with their primary care specialist, or if they said, no, I'm good, I don't need to come in. I do track the ESI scores that Dr. Taylor asked about. I find them through chart review. I've asked to see if collective medical can include them, and they did not have that availability at the time. They did say that they could include a readmission risk score, which is a little bit different. But I know my patient population pretty well, and I'm not sure that we needed that score right now. I also track the insurance and whether or not they went to the ER on a weekend or a weekday. So I also get faxes through our EHR, and those are come in real time. And I think that's something that the hospital started, Lourdes Hospital started, but I get like, okay, Jane Doe just got to the ER, she's back again, she's got, cyclical nausea and vomiting, this is, and so I recognize her name, I know she's in the ER, I keep that on my list to track and follow up with in case it doesn't show up in my report the next day, but it almost always does. I don't get emails from collective medical, and I'm okay with that because I get 20 notifications a day, and I would rather have a spreadsheet. And then I take all this data at the end of the month, and I use all of these columns to kind of, how many patients did I have that had 10 or more ER visits? And so in August, we had 227 ER visits, and 9 of them were for folks who had 10 or more visits. And a lot of these are in brown or that orangey color because they've had repeat visits, and a lot of these are the same person. And I have an annual, so this is monthly, and then I pull over some data so I can track for the whole year and really get a feel of what our patients are doing, where they're going, why they're going to the ER, and how well we're doing in our follow-up process. So this chart shows by month all of our patients who have presented to the ER. The first column is total number of visits. The second column is if they were contacted within 7 business days of the visit, and that doesn't always mean that I personally called them, although it usually does. It could mean that they called the clinic themselves and scheduled a follow-up. It could mean that I, doing chart review, found out that they already followed up with a specialist that they needed to, and so I don't need to call them. And then this yellow column shows how many primary care follow-up appointments we have scheduled for that month. So we see a lot of ER follow-ups. 113, 99, 85, 83. I mean, yeah, so 90, 83, 79 to 115 ER visits, follow-ups a month. I also track how many patients went and saw a specialist after their ER visit. It's a lot less, but it's still pretty significant. I mean, 76 ER follow-ups at a specialist clinic. The red column is how many folks left the ER and they're like, nope, I'm fine. I don't need to follow up. It was a one-time thing. I took my antibiotics. I'm good. And then this little tiny column at the very end, these are how many folks that we have missed. Sometimes it happens because I didn't get the notification within 7 business days of them going to the ER. For some reason, they're not on our roster, or they went to the ER and they said, I don't know who my PCP is. And so we didn't find out until they called us 2 weeks later that they went to the ER. That's usually the case. Every once in a while, it's because I am incredibly busy. Sometimes it's because they go to the ER for a suture removal, and they really don't need to call them within 7. I've already called them after they got the sutures. And if I read the ER note when, wound looks great, it's healing well, there's no reason for me to call them. And I can, I have filters. I can filter it by provider. So if, say, Dr. Adling wants to know how many of his patients are going to the ER every month and how many follow-ups he's got, I can show him right away. I can do it by patient, so which clinic they're from, by visit facility. So I want to look at everybody who went to wards that way too. It's really useful data, and Collective Medical made this possible for me to do, so thank you. I also look at where our patients are going. So this is every month, and then different colors in part of the column is where they went. So we've got Lourdes, Trios, Cadleck, and then outside of the Tri-Cities area. And again, I can filter it however I want. And I've got this one, which is our ESI scores, which, yes, Collective Medical doesn't pull those, but they direct me where to go to find it, right? They give me the patients. They tell me where they went. They tell me when they were in the ER, and they give me the diagnosis code. And so I know where to go to look for these scores. This is really cool to be able to pull, because an ESI score of 1 is a patient goes to the ER, and they're like a code blue, and they need everything, and they need it right now, or they're going to die. So they really needed the ER. ESI score of 5 is like they came in and they're like, I need a refill on my hydrocortisone cream. Not really probably necessary to be that. And that's really important data for us to be able to track and trend too. So we can see,
Question before you move on from this. You mentioned earlier that that there is a value in the readmit score. But you know your patient population pretty well, so you don't really need it. But for those that aren't really familiar with the patient populations or what that readmit score is, can you elaborate a little bit more on how that can be of use for others?
Yeah, I mean, if you don't know your patient population very well, or you're new at this and you're just learning, knowing that they're a high risk for readmission can direct you to reach out to them sooner than somebody who is a relatively low risk for readmission. If your goal is to keep folks out of the ER and the hospital, it can help direct you. If you're overwhelmed, you can't do it all, where do I focus my time? That would be a really great way to go.
Great.
Does that answer your question, Martine?
Yes, thank you so much.
And then I can also, Collective Medical also pulls a rolling, for us, a 12-month ER total. So it's this visit plus all the visits in the last 12 months. And we have been tracking folks who have been 10 or more times to the ER in the last 12 months. And I know a lot of places go 5 or more times, but we had such a big patient population that I had to kind of pare it down even further. And so we've got patients with up to 33 visits in the last 12 months for the ER. And so that's where I direct my time and my heart. And I'm trying to reach out to these folks, see what we can do to support them. Why are they going to the ER? They have a primary care provider. Let's encourage them to come here. Let's educate them on, well, yes, the ER is great for certain things, but it's not really the best care for you holistically, because they're going to do what they need to do to stabilize you and send you home. The goal is for you to follow up with us, and we can do all the outpatient testing if it needs to be done and direct you where you need to go. So this has been fun information for us to kind of look at and track and trend, and it's going down. At least this month it did significantly. And actually, I think 2 of them was the same patient who went, and then he went again. So there's a little bit of repetition there, but be interesting. And it was a lot more useful looking at it like this than like this, because this makes total sense to me because I do it all day, every day. Trying to explain what I'm doing to other people, the graphs are a lot nicer. And that kind of leads me into what the approximate amount of time I use to track and follow up on collective medical alerts per day or week. That was another question that I was asked. I work 40 hours a week, and I probably spend 75–80% of my time doing this. I get them every day. I do chart review. I summarize their ER visit. I call them and I say, hey, you know, we got a notification that you were in the ER last week. I just wanted to make sure you were okay. And I have never had a patient be mad at me for checking on them. And it's kind of a relief because they're like, wow, you're not calling me about a bill. You're not calling me to like shake your finger at me and say, why were you in the ER? You just want to make sure I'm okay. How amazing is that? And then, you know, if they need help, oh yeah, they wanted me to go to ortho, but I have, you know, this insurance and I need the referral from primary care. I'm like, okay, well, I'll go talk to your doctor and see if we can get the referral. Or, you know, I'm really not feeling better. I've been on antibiotics for 4 days. And I'm like, well, let's get you into the clinic. Let's follow up with you, see how you're doing, see if your doctor has any other recommendations to do. We have prevented ER returns with this. I've gotten patients who we haven't seen in a while and they're on our roster and they show up in an ER and I call them and they're like, yeah, I'm like, you know, you haven't been in like 2 years. Let's get you in for an annual wellness exam. This is so useful to us and it's so valuable to our clinic. And it's, I mean, our providers and our MAs and the support staff, they just don't have the time for this because they're in the clinic seeing patients all day. And so this helps our patients not get dropped off radar. And I don't like it when people fall through the cracks. I'm OCD if you can't tell. So I like to sure that our patients are being taken care of. And I think that this is a really amazing thing that we are doing as a clinic. Hoping to get some help. There's only one of me, and we have a full-time nurse navigator position open. So I'm just gonna like put that out there in case anybody's curious. That would be cool. And then the last question that Martine sent me was to share a story about how collective medical has impacted the care you provide for your patients. And I think, you know, I think I've already kind of touched on it a little bit. It's just and then, you know, I don't even know. We have patients who go to the ER and they call and they come into the clinic and I, through chart review, find out that they were assigned a consistent care case manager, you know, but consistent care had never been able to contact her. So I brought my phone into the room after the provider was done and we called her consistent care case manager together and we set her up with housing and glasses and dinner for that night because she hadn't eaten and didn't know where her next meal was coming from. They got her a cell phone. And since that happened, that was in, I think, June, she is clean and sober. She has a job. She has a steady place to live. She has glasses. She's in contact with her consistent care case manager almost daily. And she'll just send her a message like, hey, how you doing today? Or, hey, it's a great day to be alive. It's amazing. We never would have known if we didn't have collective medical notifying us of all of these things. There are notes in there too. Everything. It's magical. It's so worth it. Every penny. I am so happy to have this.
Wow. Thank you, Sarah, for, you know, that's, I mean, that's a really, you know, wonderful story of, you know, what you guys are able to do, you know, are able to intervene, not have that patient fall through the cracks and just have a great outcome. So thank you for sharing that story and all of this information, you know, that you have shared with us today. We do have a couple of questions, some here in the chat. This one comes from Michelle Sullivan. She works for Yakima Neighborhood Health Services. And it says, do you also receive summaries from the hospital regarding the visit? If so, how do you deal with this duplication?
I do sometimes receive the summaries. Lord sends it to me, Caroline sends it to me. Sometimes outside hospitals do, and they come in through our EHR, and they come into my special like inbox, and I just sure that I have them on my master list on the Excel spreadsheet, and then I close it out. And when it's time for me to follow up with the patient, when they come up next on my list and I know that it's time for me to call them, I'll use that summary to look at why they were in the ER, what they did, what prescriptions they got, and then I write a very short version of that summary and send that to the provider in what essentially is an email, but it's through our EHR. It's called a patient case. So I'll summarize the summary, and I will add in what the patient and I talked about when I reached out to them. So, continuing questions and concerns. And then the provider, it's still there for the provider to review if they want to, if they need to look at the things more in depth. But if it was a very simple cut and dry, they went in for this, they had a UTI, the UA showed this, they were given this antibiotic, then that would saves the provider time because they don't have to hunt and peck through that big long summary that they get from the hospital. It's in a, it's in a stable, what's the word I want to use? Outline. So I have specific templates that I use. I have an ER follow-up template and a hospital discharge follow-up template. So it's consistent all the time. And so they know exactly where to look for the pieces that they want. Did that answer that question? Sorry if I went overboard on that.
Yes. Yes. So that we got a yes from Michelle. One more question here. For those patients that you reach out and call, are they aware that they are being, kind of case managed? And what's the reaction that you get from those? You kind of mentioned it a little bit during your presentation. And do you think that's, helping with the decrease in ED visits in your patient population?
So they're usually not aware that it's like a case management situation because it's not exactly that. But patients are usually pretty surprised, like, wow, they told you I was in the ER. How'd you even get that? And so then I have to go through, like, it's all HIPAA compliant. It's this really cool company, and they keep, have like feelers out everywhere. It's like the medical mafia, and they know where you are, and they tell us so we can follow up with you. And it lets us take better care of you. And so patients are usually pretty excited about it. They're like, wow, I didn't know that. Because I've had patients that are like on a road trip in California and they get in a car accident and they break their ankle. And I call them and they're like, how'd you even know I was in California? and so they're like, yeah, I do need an ortho follow-up in the Tri-Cities. Can you help me coordinate that? And I'm like, I would be happy to.
Great. Thank you. And we're coming here short on time. So we have 4 minutes left. I don't know if anybody else in the audience has, maybe one more question before we close this presentation. So I'll give you a few seconds to see if there's any questions.
Martine, Laurel has one, please.
Go ahead, Laurel. Hey, Sarah. I just had a quick question. Hi. So are you able, I love your summary format, and are you able to share that with the clinicians and provide that information for them in any setting?
Or it's just a Word document.
No, your summaries, like how you were showing, like the number of patients that had like the one that had 33 visits to the ED, all your pivot tables. And, yeah. Is there an opportunity for you to be, part of, I don't know, I don't know if Dr. Taylor's still on the line. If you guys have worked out that information is shared with the doctors and advanced practitioners.
I've shared some of it with some of the providers, and I use it to kind of let them know when they're like, I really want all of my ER follow-ups to be 30 minutes. This is evidence that we just don't have time for that. And so I've done it that way, and they don't seem super interested. I've tried to show our providers all of this.
Okay. Thanks, Sarah. It's wonderful. I think it's just amazing data that you guys have pulled together.
Oh, thank you.
Yeah, thank you, Sarah, for all the information that you shared with us, the stories, and thank you for being part of this learning collaborative.
Oh, of course. Thank you for inviting me. I'm happy to share.
Yeah, thank you, Sarah and Hannah and Kate, all of our wonderful presenters today. As we're just wrapping this up briefly, if you all could take just a few quick minutes to fill out our survey, giving us some feedback on this month's Learning Collaborative, that would be very helpful. It is in the chat box. Our next Learning Collaborative next month will be November 12th from 9 to 12. That might supposed to be 10 to 12. But it's going to be on cultural competency. Diane, did you want to talk briefly about that?
Sure. So it's going to be about cultural competency, and we're going to give you lots of examples of how to work with all different types of patients, and so it'll be a good learning collaborative, and we're excited to present it for you.
Diane, you might suggest, this is Carol, you might suggest that there's quite a bit of diversity, equity, and inclusion that's involved in this particular cultural competency training.
Yes, it does. Thank you, Carol.
Welcome.
I have contact information if any of you want to reach out specifically. And other than that, thank you all so much for attending this month's Learning Collaborative. And again, thank you to all of our wonderful presenters. Have a great rest of your day.
Thank you.